Hello, everyone. This is WEO Secretariat speaking. On behalf of the organizers, we wish to welcome you to the Colorectal Cancer Screening Committee's webinar on the evaluation of new tests. There are a couple of housekeeping rules we would like to bring to your attention. The chat function, as well as the raise hand function, are turned off for this webinar. Should you have any questions or comments, please use the Q&A box. Please note, your questions will not be addressed during the webinar, but we will follow up afterwards. Your questions and comments will guide the conveners in further planning. As you can see, we have an excellent lineup of experts for this webinar. Each presentation will be followed by discussion. So without much further ado, I would like to give the stage to CRCSC Global Chair, Evelien Dekker.
Thank you very much, Alexandra, and not only for your introduction today, but also for the perfect organization of you and Ruth and the whole Secretariat for all these webinars. So I would like to greet everyone all over the world. It's early evening in the Netherlands, in my country. It might be a very different time in yours, as I was just discussing with the chair of this webinar with Graeme Young, who's in Australia, sitting up at midnight. I'm very happy to see you all online. I'm looking forward very much to this this wonderful webinar. As you know, we have set up a weekly webinar for the coming other 5 weeks, all before the plenary session, which is as usually aligned to the DDW. I think this is a perfect moment, as we have all the online meetings, to have very active expert working groups. We know from last week, when we had a great webinar on image-enhanced endoscopy and polypectomy techniques, that we had many people online, many more than we would have had when we would have had a live session, because it's always so difficult to decide to which session you would like to go. Well, in fact, this time you can be with us every week with a different expert working group. So of all the webinars, I'm also looking very much forward to the program of today, which I think is really interesting on the evaluation of new tests. And I'm so happy that Graeme Young from Australia, the former chair of the global chair of the working group, has resurrected this expert working group, because I think it's a very big topic with all the new tests coming up. So please, Graeme, take the seat, and thank you so much for all your work and your expertise.
Thanks very much for your introduction, Evelyn. Good morning, or should I say good afternoon or good evening, wherever you are. I guess, Evelyn, I didn't resurrect it. I think I was resurrected was rather more to the point here. But I'd like to thank firstly the co-chairs, Carlo, Senore, Bob Steele and Bob Bresalier. And they, together with myself, are delighted that you have joined. We have over 300 people who've expressed interest in the webinar, and we've received specific comments for almost 50 people in terms of how we might proceed with the content of this seminar. Well over a dozen, perhaps close to about 20 ideas emerged in those comments. And what we've done is chosen 6 of those to start this process off, and they will be the topics of the presentations today. But this is going to be an ongoing expert working party for some time as we move through and we review all of these issues. So I welcome you to the meeting, and I'd like to just start off with an introductory comment. So you will be aware that back in 2016, we published a paper entitled Recommendations for a Stepwise Comparative Approach to the Evaluation of New Screening Tests for Colorectal Cancer. That was very much needed at the time. The working party took 4 or 5 years in its deliberations, and you will see the names of the people there who made crucial contributions to that publication. The scope of the 2016 recommendations was to develop practical advice on how best to compare new with proven existing screening texts, the ideal context, the informative endpoints, and the appropriate study design. But the focus for today is to commence revision considering the new developments in biomarkers and technologies, and these have been substantial, and that's why this process has been resurrected. There's also widespread implementation now of organised population screening. And for example, the prevalence of colorectal cancer screening of colorectal cancer in screening populations in the US is way down to just 1.5 per 1,000 people now, which poses major challenges for us in the research area. And then finally, and most importantly for us as a world global organisation, there are differing goals for screening and very different regulatory processes that apply throughout the world, so that any recommendations that we develop need to take into consideration the fact that things are very different from country to country, and our guidance must be able to cope with all of those different situations. Finally, I do want to remind you that screening is very much a complex process. We won't be talking about that process today, but it's very important to note that a test is not developed in a vacuum. Biomarkers to be used are considered because of their relationship to screen relevant neoplasia, that is to cancer and the advanced pre-invasive precursors. To date, methods have proven to be of clinical value for early detection are based on bleeding and structural observation by endoscopy. But the technology, and that's very important because a new biomarker might be detecting a different biology. The technology for the test must also be able to meet diagnostic laboratory requirements and regulatory scrutiny, because we can't even start without this process being practical. The second point is that accuracy in its key aspects is determined in selected cohorts by the phased process that we described in the 2016 paper. And what that happens in the early stages is that the test criterion values for positivity, hence sensitivity, specificity, and other operating characteristics, receive preliminary estimates. The test is then applied in an intended use population for assessing accuracy, feasibility, and acceptability. And the thing that is very much emerging now is that this includes resetting the criterion value. So the idea used to be that it used to be set early in the process, but we're now finding that firstly, it needs to be reset later as you get to the intended use population, but also needs to be adjusted according to the goals of the screening program. So that is the introduction for the present moment. You will hear later from Bob and from Bob Bresalier and from Carlo when they speak as we move through the programs. So thank you, Alexandra. If you wouldn't mind just starting the recording on my first presentation. First issue for discussion in today's webinar. What I plan to do is to outline what we want of a new test and the concordance of this with guiding principles shown in the 2016 publication. I'll cover several specific areas, particularly accuracy measures and then scenarios for practical application, and then finally conclude on what it is that we do need to know about a new test. We specified in the 2016 publication that a new test must be effective and at least as good as the best existing test. Otherwise, why have a new test? The test must meet diagnostic laboratory requirements and stand up to regulatory scrutiny. The testing process, that is the sampling, logistics and risk, must be acceptable to the screenee. And finally, we must be confident that the lesions it detects are worth detecting and not just indolent. What I propose to do today is to explore additional points of clarification. Firstly, the test endpoint, that is the criterion values for test positivity and hence follow-up colonoscopy, should be flexible to allow adjustment to meet program goals as determined by policy and healthcare providers. Secondly, that accuracy, and in particular sensitivity and specificity, must be appropriate for the context of use. And thirdly, that the positivity rate in the population must be feasible and the test must be cost-effective. In effect, this sets us a balancing act of multiple dimensions that you'll hear more about later from Bob. So what accuracy is good enough? Consider detection, because this determines the mortality incidence benefit. A more sensitive test returns more true positives. But also we have to consider the burden associated with detection, because this determines cost and feasibility. A more specific test returns fewer false positives. So we learn a lot by determining if a positive result is true or false. Each is readily compared to a comparator test proved to be effective by randomised controlled trials. In 2016, we concluded that guaiac tests are the minimum standard, noting that their once-off sensitivity is 30 to 50% and the specificity is in the range of the high 80s to the high 90s. We also concluded that FIT are acceptable, but they are clearly superior to guaiac tests. We now need to make it clearer what this means. So what are the desirable values for sensitivity for a test? What I propose is that for cancer, sensitivity should be at least 70% in absolute terms and relatively should be at least as good as a good fecal immunochemical test. Why set this standard? Well, in the graph on the top right, you will see that in a 2015 publication, we pointed out that the sweet point for sensitivity of fecal immunochemical tests was about 75%. And this was indeed confirmed in a subsequent publication a few years later by Tom Imperiali, with a 75% sensitivity using the standard cutoff for fecal immunochemical tests. The United States Preventive Services Task Force suggests an acceptable sensitivity to be at least 70%, but personally, I think we should be able to do better than that with a once-off test. It is more challenging to set a desirable value for the sensitivity for advanced pre-invasive colorectal neoplasms, that is, advanced conventional adenomas and advanced cess-ulcerated lesions. It's being proposed that at least 25% in absolute terms, and certainly at least as good as a good fecal immunochemical test is necessary. But Cologuard has set a higher standard of at least 40%. The desirable standards have not yet been set or agreed upon, and it's unclear what proportion of advanced pre-invasive neoplasms will progress to cancer within a decade. For the moment, a working standard might be a sensitivity for advanced colorectal neoplasia, that is cancer plus advanced pre-invasive lesions, of at least 40% with a once-off test. What about a desirable specificity? Suggestions from the literature are that this should be in a range of 92 to 98% in the target screening population, perhaps ideally 95% or better, certainly equivalent to a FIT set at an equivalent sensitivity. Why this standard? Well, again, this corresponds approximately to the sweet spot in our 2015 publication and is confirmed in the Tom Imperiali publication, where the median specificity for FIT was 95%. The United States Services Preventive Task Force suggests acceptable specificity to be at least 90%, but for many other countries, this would be considered to be too low. If we take these measurements, then it is likely that we'll end up with one of two scenarios. The first is that the new test has a superior true positive rate, that is, a better sensitivity. In this case, one should examine the resultant false positive rate and calculate the number of colonoscopies needed to detect one lesion to judge efficiency, and finally decide whether the new test is worth it or not. The other scenario is that it will have an equivalent true positive rate, and so one then needs to ask, are there other benefits, such as a better false positive rate, that is specificity, lower costs, higher participation rate in the target population, and so on. Again, one might need to calculate the number needed to colonoscope to make a final decision, and prior consensus on what is required is crucial. Finally, it is apparent that non-inferiority study design is very important. In many jurisdictions, it's the population positivity rate that sets up the test configuration. Here, it's important to match the total of true and false positives to resource capability, because this determines the number of colonoscopies needed. At the chosen rate, the new test must pose some accuracy, acceptability, or cost advantage over the established test. And it should be noted that positivity rates of 5, perhaps, or even 7% are needed for decent detection of advanced pre-invasive lesions in the colon using fecal immunochemical tests. In practice, one then needs to follow the 5 steps listed here, and the new test must be compared with the comparator at an equivalent population positivity rate. Why is a comparator test important? Well, firstly, neoplasms that bleed or that are detected by visualization, that is structural means, are worth detecting because early detection is proven to reduce mortality and/or incidence by randomized trials. Secondly, detection by some other method, for example a genetic or a molecular test, might reflect a different biological behaviour where treatment either might not be as effective or alternatively the lesion might be indolent. Showing that a new test can detect those we can already pick up by established means provides confidence. So in conclusion, what do we need to know about a new test? It's obligatory that it must be effective and at least as good as the best existing tests. The test must meet diagnostic laboratory and regulatory requirements. The testing process, such as sampling and logistics and so on, must be acceptable to the invitee. And any additional neoplasms that are detected must be worth detecting. But we're also proposing clarification on some of these points. Accuracy claims must be established in an intended to use screening population, and ideally a sensitivity for cancer of 70 to 75% and a specificity for advanced colorectal neoplasia of 90 to 95% should be achieved. The test endpoint must be flexible to allow adjustment of operating characteristics so as to meet the goals of a screening program, because different screening programs have different needs. And finally, if colonoscopy workload drives a program's goals, then choice of a flexible test endpoint that delivers such a workload, it must also deliver acceptable accuracy. Thank you. I can hardly thank myself, but I just wanted to make the point that obviously a number of these issues are going to be somewhat controversial and they need to be worked through as we move forward. Samir, thanks very much for joining and agreeing to act as a discussant on a couple of points. We've got a couple of minutes for you, so can I hand over to you? Thanks very much.
Sure. Thanks, Graeme. Can you hear me okay?
Yes.
Okay, great. So that was a really thought-provoking presentation, and there's so many really interesting issues here. I want to bring out a couple things for discussion. One is this issue of a comparator test. And I know there's a camp that, as you are arguing, that we really should have a comparison to an established test like fecal occult blood test. There are others I know who have argued that we should just be able to use colonoscopy as a reference standard. And I actually think there could be a middle ground that we should consider. There's obviously now been a wealth of data published on the effectiveness of sigmoidoscopy for reducing incidence and mortality. And we think we understand the test characteristics of sigmoidoscopy pretty well. And I wonder if we might be able to find a way to allow for studies to consider just having colonoscopy as their reference standard, assuming every single person who's in the study gets that colonoscopy, and think a little bit about how we could use that sort of the sigmoidoscopy part of that colonoscopy as the standard, as one of our ways of comparing. So that's one issue which I think we really have to carefully consider, because obviously the studies become much, much more complex. For example, if we're going to say, as was done in the Cologuard study, that everyone has to do a Cologuard, a FIT, and a colonoscopy, it feels even more daunting if you're thinking about, well, we've got a new blood-based biomarker, you need the sample, then you need your FIT, for example, and then you're going to do a reference colonoscopy. So that's one thing that I was thinking about. I think the second thing is this issue. I think we should unpack the issue of whether a new test is likely to have sufficient sensitivity and specificity to reduce incidence and mortality. And there should be standards around that based on the test characteristics. I think then there's the second issue of efficiency. So you might have a very expensive test. You might have a test that has an intolerable false positive rate, and you may choose not to use it in the population, but it still could be a test that, if you could afford it, and if, for example, you had the resources to deal with the false positives, if it was implemented, it could impact incidence and mortality. So I think separating those issues could be helpful. And then a couple other comments, and then we can open for discussion. I have run into this problem in thinking about how do you count the low risk adenomas as far as false positives, and especially as new biomarkers may get better at measuring the actual pathophysiology and markers of adenoma progression. I think we have to think a little bit about not counting detection of low-risk adenomas against a test. And so I think we have to think about the definitions of specificity. Another issue is taking into account the test failure rates. I know you brought up the point that we have to meet the lab regulatory standards, and whatever the regulatory body is has to set the standards. But we know, for example, again, from the Cologuard study, if I recall correctly, in that initially, there were about 5 to 6% of the samples that couldn't be processed for one reason or the other. And the question is, do we count that against, should we count that against sensitivity or not? You could imagine a biomarker that might have a higher test failure rate, and for the samples you are able to process, it may have excellent test characteristics, but if, for example, 10% failed, it's not going to be practical. And then I think the last point I'll just make to get off is the issue of, I think we have to talk about sensitivity relative to specificity. So when we say that the sensitivity has to be 75% or greater, I think we should also say at a specificity of at least 90% or 95%, the sensitivity has to be 75% or greater. Otherwise, there's that potential for gaming.
Samir, thanks very much. It's frustrating in this system at the moment that we're not able to have live conversations. So I appreciate these. Just so that everyone understands, we're taking all of these comments on board and they will all be addressed. And there is one comment from an external person to say that we need to keep in mind that if we have to use colonoscopy as the reference standard for evaluating all these parameters, study sizes in intended to use populations now need to include 15,000 people, for example, in the US. So this is a big issue. Samir, look, thank you very much. We need to move on and keep the process rolling. So I'd now like to introduce the next presentation from Uri Ladabaum from the US, who's going to discuss what is the screening target. Thanks very much, Uri.
Thank you very much, Graeme. It's a true honor to present. Can everyone hear me okay? Okay, I hope that's a yes. When I was presented, thank you. When I was presented with these questions, I first had my thinking fast knee-jerk reaction as follows. Do we need to look beyond early stage CRC? Do we care about pre-invasive lesions? Reflex, yes, of course. Which ones? Well, the advanced adenomas and the advanced cell-ulcerated lesions. And how do we assess benefit on colorectal cancer incidence and mortality if we don't do randomized controlled trials with long-term follow-up? Well, the answer is modeling. But then thinking slow needs to come in. And when I approached it that way, I realized the first question is to some extent a philosophical question. A better answer to question 2 is we really want to target the progressive lesions, whatever that means. And if we're going to do modeling, it should ideally be based on progression rates. And there are a lot of limitations to our knowledge here. And this should iterate with observation. Now, the problem with these answers is that they're kind of up in the clouds, and we're really trying to do something practical here. So what I'm hoping to do is to try to address these questions leading to some form of practical guidance. So question number 1, do we care about pre-invasive lesions? Well, it goes without saying that we need to find early stage colorectal cancer, otherwise the screening just doesn't work. What about colorectal cancer prevention? My vote is a firm yes. And the reason why starts with the fact that we can reduce incidence. We know that is possible. This audience is very, very well familiar with the randomized controlled trials of FOBT. I just call your attention here to the incidence reduction that has been reported in the range of 18 to 23%. So it is doable. We can take out precursors and decrease cancer incidence. In all of these trials, the curves look like this. In black, we're looking at incidence. In green, we look at mortality. Initially, there's detection of the prevalent cancers. That's in blue. Then there's actual reduction in subsequent incidence in green. The PLCO investigators have tried to estimate what was the contribution to the deaths averted by early detection and prevention. And you can see here that they estimated this 2 different ways. About 1/3 of the effect was early detection, 2/3 was prevention. So not only can we prevent, but prevention seems very important to the reduction in mortality. And for that reason, we can reduce cancer incidence. I think we should, with the caveat is that this is if resources permit. Question number 2 is more challenging. Which lesions? Well, we know some things, for instance, about size and histology, but there are major knowledge gaps, particularly about natural history of different lesions. Now, to a first approximation, one can ask, what is the colorectal cancer risk attributable to in a patient? Without lesion removal, we might say, well, it's the most advanced lesion that's still in place. But after lesion removal, it's really what's left behind, the patient, the rest of the colon. So let's look at what we know with regards to both of these. First, without lesion removal. There are the classic cross-sectional data from Muto et al. From 1975. This table looks at the percent of lesions with carcinoma. And as you can see in the highlights, the lesions over 2 centimeters, in that series, 46% had carcinoma. So larger lesions seem to be important. We don't have a lot of prospective data on large lesions. The Stryker study is to some extent unique. These are polyps detected by barium enema, not removed. And 20 years out, 24% of patients had cancer, not all at the site of the initial polyp, which is a different issue. But you can get a sense of the rates here. Not all of them progress. What do we know about small or diminutive adenomas? A few years ago, there was a systematic review, not a lot of data, about 1,000 adenomas, 1 to 9 millimeters, but few seem to progress. The time horizon was short. 6% approximately went on to advanced adenoma after a couple of years. Maybe one went to cancer, but no long-term data on the 1 to 9 millimeter range. Dr. Sekiguchi recently presented at the polypectomy working group session. Japanese investigators have been characterizing diminutive polyps very carefully, and in patients who only have those lesions, they have been leaving them in place and observing over time. And what you can see in this figure is that patients with untreated diminutive adenomas, very carefully characterized, they do not look malignant, under 5 millimeters in blue, have very low rates of cumulative advanced colorectal neoplasia, 9, 10 years out. And the numbers are very similar to patients who have no polyps detected. What about histology? Again, from the Muto paper, villus histology associated with cancer. Again, percent of lesions with carcinoma, villus compared to tubular, a rate of 40% in that series compared to 5%. So villus components matter. Now let's talk about what happens after lesion removal. And maybe this tells us more about the patient, the remaining colon, with the caveat that we have to deal with the possibility of incomplete resection. We're not talking about that today. A recent systematic review and meta-analysis has aggregated the data. These are the data for subsequent colorectal cancer incidence, but the numbers for mortality are similar. These are high-risk adenomas as defined by greater than or equal to 10 millimeters, villus or high-grade dysplasia, or multiplicity, at least 3 adenomas. And the odds ratio for subsequent colorectal cancer incidence for these high-risk adenoma patients compared to no adenoma, 2.9. Again, mortality is similar. By the way, I think this is a call to reflect, a call to action. This should challenge us. Why does this risk remain this high? We're not discussing that today, but if you're interested, please come to the surveillance and right-sided lesions section. We'll attempt to discuss this. Contrast that with low-risk adenomas, defined here as 1 to 2 adenomas less than 10 millimeters, odds ratios compared to no adenoma, greater than 1, but slightly, 1.26. So these patients are at slightly higher risk than if they had nothing. And we now also have data on the independent predictive effect of sessile serrated lesions. Again, this is after resection, so we should scratch our head a little bit about why that persists. So if we say we can reduce colorectal cancer incidence, and what we've been doing is to remove non-advanced as well as advanced lesions, and we think that the non-advanced adenomas, at least in the near or intermediate term, probably don't have very high risk, so that's a minor effect. We postulate that there are low-risk sessile serrated lesions that are minor effect. That leaves us backing into the conclusion that the advanced adenoma removal is probably the major effect, and probably there's also an important effect of the advanced sessile serrated lesion. But is there a better answer to this reflex of advanced adenoma and advanced sessile serrated lesion? I found this to be a very provocative perspective published in 2012, the adenoma hunt in colorectal cancer screening, defining the target. And we're extremely fortunate that one of the authors of this paper, Dr. Carvalho, will be the discussant. So I look forward to her comments. A couple of very provocative quotes from the paper. For most of the greater than 1 million new colorectal cancers annually around the world, it is simply not known whether these cancers have progressed from small or large adenomas, tubular or villus adenomas, nor from flat or polypoid adenomas. And then the following comment. The adenoma carcinoma sequence model has started to live a life of its own, and the perception has overtaken real-life observations. So this is the conceptual framework for potential progress that the authors propose. We start with normal mucosa at the top. The patient can develop adenomas, and you can see the cellular mechanisms there. But 95% of these lesions or so never progress. That's the stop sign on the left. Only a few of them, maybe 5%, progress. And the question is there a target signal that we can use to determine what are the progressive adenomas? Realize we're talking about molecular targets in an era of potentially molecular tests as opposed to morphology tests. Now, this is a tough nut to crack, but aspirationally, can we move forward with this paradigm? How to assess benefit? Well, very large numbers, very long follow-up if you're going to do RCTs. The last position paper on this essentially acknowledged that's not feasible. So we are left with test performance characteristics and extrapolation, and the most formal way to do this is modeling. But a caveat. Now, these are the inner workings, the under the hood transition dwell times that used to be in the SysNet models. There have been updates, but the investigators, I think, were very courageous and transparent in publishing that among their 3 models 10 years ago, the adenoma incidence to adenoma progression time varied wildly, 7.6 years to 24 in the middle there, and the preclinical cancer dwell time, 1.6 to 4 years. You can see how if you model specific intervals, specific test performance characteristics, then the conclusions could really depend on these assumptions. And what about the serrated pathway? Most models don't yet incorporate this. One that does, the ASCA model, assumes 15% of cancers come from serrated. And maybe that's true, maybe it's not. So I think we need this cycle. The models will make predictions, but they need to be pressure tested against observation and recalibration as the Miscan model has done. So my conclusion, which I hope approaches practical. Do we care about pre-invasive lesions? Yes, we're feasible. Which ones? I think advanced is okay for now, but can we challenge ourselves to molecular targets? And how do we assess benefits? I'm a believer in modeling, but it has to be coupled with observation, and we have to iterate between modeling and reality. Thank you very much, and I very much look forward to Dr. Carvalho's comments.
Thanks, Beatriz. If you'd like to go ahead.
Okay, thank you. I will share my screen now. Okay, I hope everyone sees my screen and hears me good. Okay, so I will proceed with the discussion. Thank you very much, Uri, for your very clear presentation. And indeed, I think we have a challenge that we need to face, and it is indeed a screening target. And from your presentation, it is clear that we should target the early cancers and the precursor lesions that are at risk. However, the big challenge here is indeed, like you said during your presentation, which precursor lesions are really at risk of progression because their natural history is interrupted when they are resected. So the current advanced adenomas and advanced serrated lesions, we agree, like you also showed the numbers, that they are not really the ideal surrogate of risk, because we know that not all of them will progress to cancer. And because of that, will lead a lot to overdiagnosis and overtreatment. And one thing on top of it that I would like to really call the attention is that the fact that we are using advanced adenoma as a surrogate of risk, then it leads us also to underestimation, perhaps, of the performance of the screening tests that we are using. So how do I propose to move forward? Now, like Uri mentioned in the presentation, molecular changes are involved in the progression of cancer. They should be more accurate to detect this risk of progression. And from cross-sectional studies analyzing precursor lesions that already proved to have progressed to a cancer, so for instance, malignant polyps, this can help identifying the molecular changes that are associated with this progression. So therefore, the path that I suppose is the way to move forward is to incorporate progression-associated molecular changes as biomarkers in new screening tests, so screening markers, and on the other hand, use them also as these progression molecular changes as surrogates of risk to be able to evaluate the performance of screening tests. So use them as intermediate endpoints. So what is the current status then of these promising molecular markers? Here I would like to show an example, because there is much evidence already in the literature that the occurrence of chromosomal instability plays an important role in the transition to malignancy. And specific chromosomal copy number variations were associated with this adenoma to carcinoma progression, looking at malignant polyps, for instance. And we also have nowadays in our hands preclinical models like organoids that are able to mimic the natural history of the adenoma to carcinoma progression. So taking this together, I would like to conclude this discussion with the two suggestions. So the way I think we should move forward is to try to use good evidence molecular markers from the literature that represent the biology of progression and use them as markers in new screening tests. Although we are not there yet, it is possible to detect copy number variations in body fluids, but technology is not yet completely feasible. So we have to continue working on that, but I think we will be there in the coming years. And another way is to use them as intermediate endpoints. So I think it's time to consider when we perform a screening study to test a new screening test, then we can use adenomas that are characterized by these molecular risk features as intermediate endpoints, so that we can evaluate the new screening test in comparison, of course, with the classic advanced adenoma intermediate endpoint. So with these two statements, I think I close my discussion. Thank you for your attention.
Thanks very much, Beatriz. It's greatly appreciated to both you and Uri for opening up this issue of the fact that we're not that clever at identifying the adenomas that matter. And we look forward to seeing how the biomarkers are going to be proven in this context. That will be the interesting challenge. But thank you very much. Next presentation, and the title of the presentation is Complex Algorithms for Test Positivity Criteria, Approaches to Address This. The presentation will be Tim Kortlever from the Netherlands, and the discussant will be Patrick Bossuyt. Thanks very much, Tim.
Yes, thank you, Graeme and the WEO for the opportunity to speak here tonight. My name is Tim Kortlever. I'm a medical doctor and research fellow at the Amsterdam UMC, the Netherlands. And today I want to discuss with you something that we see more and more often applied in colorectal cancer screening research, and that is the use of algorithms. My main message tonight specifically will be talking in the upcoming 10 minutes about three main issues and possible solutions of those issues. And the first issue is the state of development of algorithms, which can be improved. The second issue is the flexibility of algorithms to be applicable in different settings. And the final issue concerns transparency, and I will be talking about so-called black box algorithms. But before we dive into the world of algorithms, I would like to tell a little bit about myself, as many of you won't know me, and also give you a short introduction on algorithms. As I've said, I'm a research fellow in Amsterdam, and I'm currently conducting a randomized controlled trial where we investigate screening with an algorithm versus screening with FIT in the Dutch CRC screening program. If you're interested in the details of this trial, then you can find them on clinicaltrials.gov. And besides that, I'm also doing a systematic review at the moment where I evaluate the available algorithms that include FIT and colorectal cancer screening. Now, what do I actually mean with an algorithm? For my definition, an algorithm may be described as a statistical method or a list of instructions to describe the relation between an outcome, for example, colorectal cancer, and one or more variables. And how would that look in colorectal cancer screening? Well, imagine that you have a screening population, and normally you would have the FIT for that population, and you would refer with a positive FIT to follow-up colonoscopy. But imagine that you can have multiple tests. So you can offer someone a FIT, but also another additional stool test, for example, a molecular marker, or a questionnaire, questions on family history of colorectal cancer or smoking. And then you can combine those results into a mathematical equation, for example, a logistic regression model. And that model, that algorithm that can calculate the risk of colorectal cancer, and the people with the highest risk can be referred for follow-up colonoscopy. The advantage of this method is that you can combine multiple pieces of information that may predict presence of colorectal cancer and thus improve the screening test. But the obvious disadvantage is that these algorithms can be quite complex, which makes them harder to use in practice. So the first thing I want to address is the development. And this is the current development pathway. There you can have four phases. Phase one is model development, where you really identify the predictors and fit the model and do internal validation. The second phase is external validation, where you take the same algorithm and validate it in a different cohort. It may be either geographically distinct or temporal distinct. And the third phase is impact evaluation. And that can be a prospective study where you evaluate the algorithm prospectively against, for example, a comparator test. And finally, there's implementation, of course. Well, in my systematic review, we evaluated algorithms and we finally included 15 algorithms. And of those 15 algorithms, we judged that 11 algorithms were not developed further than the first phase. Only one algorithm had cleared the impact evaluation phase. So very few algorithms have been developed to such an extent that they are ready to be used in practice. What about the quality of the development? Well, we also looked at that using the ProBus tool, the risk of bias assessment. And we found that especially in the domains analysis and participants, there's a lot of risk of bias. So not only are there many algorithms that are in early development phases, but there's also a lot of bias in the studies describing these algorithms. So how can we improve this? Well, luckily we can fall back on established guidelines that address the development of algorithms. For reporting, there are, for example, the tripod and START guidelines. And for the risk of bias assessment, you can use the ProBest and QuadAS2 tools. And if you have an algorithm that may be generated by a computer rather than a human, you may use in the future certain guidelines and tools that are specifically created for artificial intelligence. The second issue is that we need the output of algorithms to be flexible. And with that, I mean that the algorithm can be used in different settings and for different goals. And this is important because, like Graeme mentioned, there are many differences in the way screening programs around the world are set up. And think about differences between opportunistic versus organized screening programs, but also within organized screening programs, there are many differences. For example, the age range or fit cutoff and fit positivity rate. And finally, there's also differences in colorectal cancer incidence between countries or regions. So how can we make sure that algorithms are applicable across different programs? Now, first of all, we can encourage researchers to show really the performance of an algorithm at different cutoffs at the output. And with performance, I mean sensitivity, specificity, or positive predictive value. You can also use a classification plot, like I've shown here on the slide, which shows the true positivity rate and false positivity rate set out against all cutoffs. And in addition, the performance can also be shown for different target lesions. For example, you can show the performance of the algorithm for colorectal cancer, but also for advanced neoplasia. And finally, if you have a study where you compare your algorithm against a fit, I think it's good when the algorithm is compared to the fit at a level playing field. So they both have similar positivity rates. And by doing this, we can have a fair comparison between the algorithm and the fit. So the final issue surrounding algorithms is what we often see them as black boxes. We know what goes into the algorithm and we can see what comes out of the algorithm, but we don't really know what's going on in between. This doesn't need to be a problem, but if we are going to design algorithms that are going to be used on millions of people, we need to provide as much transparency as possible, I think, to prevent errors encoded in the algorithms. And a black box algorithm can have two reasons. The first reason is that researchers may often not publish the algorithm coefficients or equations or give very scarce details on how the algorithm was developed. And the second reason, I think, is that black box is sometimes inherent to some algorithms, for example, neural networks. And to start with that last point, when you develop an algorithm, there are several options you can choose from. You can pick a decision tree, which is a very easy to interpret and not complex algorithm, but that may not give an optimal performance. So other options you can choose are, for example, a logistic regression model, which is already a bit more complex. And most complex are the machine learning techniques. And although those techniques can be very helpful if you have high dimensional data, they come at the cost of being a black box. However, if you have more traditional data, I'd like to argue that complex algorithms aren't necessarily better. And I think this is illustrated by a recent review in the Journal of Clinical Epidemiology, which showed that across 145 comparisons in 58 studies with a low risk of bias, the machine learning algorithms were not better than logistic regression models when they were developed on the same data. So I think the first step to prevent black box algorithms is to choose the algorithm that has the most transparency with a comparable performance and not choose the newest machine learning tool. Another way in which algorithms can be black boxes for some people is by how researchers report those algorithms. Often we perceive algorithms to be black boxes, while in reality, it is clear to the people who designed them what the algorithm consists of. So to avoid this, we should encourage researchers to publish their equations and formulas. This may also stimulate external validation studies, which are highly needed. And secondly, we should encourage researchers to tell how they trained their data. What validation methods did they use? What variables did the dataset consist of, and how were those variables collected? And in line with that point, we should be aware that the population in which we train our algorithms matter. It should be a reflection of the target population. So we should encourage researchers to include participants that vary in age, but also in ethnicity or socioeconomic status. To recap, there are three main issues that we can address to improve the quality of algorithms and make them ready for real-life use for screening. First of all, we should improve the development of algorithms. That means more validation studies and decreasing the risk of bias in studies, for example, by using the tools and guidelines. Secondly, we should also allow application of algorithms in different settings, and we can do that by reporting the performance of algorithms at different cutoffs and different outcome definitions. And finally, we should avoid unnecessary black box algorithms by choosing more transparent algorithms and being clear about algorithm development. It's my belief that if we as researchers address these issues, then we can really count on our algorithms. And with that, I'd like to thank my colleagues and thank you for your attention. Thanks.
Thanks very much, Tim, and welcome to our forums and our expert working groups. I'd also like to introduce Patrick Bossuyt from the Netherlands as the discussant, and I don't think, Patrick, you've participated in our activities either, so welcome. Thank you. Please go ahead.
Thank you, Graeme, and thank you, Tim, for a very nice presentation. I'd like to add a few observations to what you just were discussing. So first, the fact that many more models and algorithms are being developed than there are algorithms that are evaluated externally, not just in a different environment, but preferably also by a different group with a lower level of investment in one algorithm. And even fewer are actually implemented in practice. So that observation is not unique for CRC cancer screening. It's a very common observation. It applies to other areas of cancer screening and many areas of clinical medicine nowadays. So it's quite worrying. And as a cynic, you could say that developing methods is a great way to create publications, but we're very far removed from improving the health of patients and the health of screening invitees. So, and maybe actually the lack of transparency and the lack of openness by the developers, your third point, is also related to the first one. So that as a community, we become more open in sharing our models and our algorithms. Actually, they're more likely to go through external validations by different groups and in different countries and in different settings. If you're not only a cynic, but also pessimist, then the situation will grow even worse. Because now machine learning actually is a buzzword, and the techniques for applying machine learning algorithms in R and other software packages are available to everyone. So we're going to see probably multiple classifiers based on proteins, microRNA, creating dozens actually of individual items in complex algorithms that will be even more obscure and more difficult to carry to a different environment and to be implemented and evaluated. So I very much support your final conclusions that as a research community, we think that some of these algorithms are very promising, that combining information is better than just relying on a single marker, but without proper external validation in different studies by different research groups and without transparency, it's unlikely that we're going to improve on the current practice. With that, I'd like to end my discussion actually after your presentation. I give back to Graeme.
Thanks very much, Patrick. That's greatly appreciated. And we're beginning to see the complexity of this issue moving forward compared to our almost naivety in the 2016 publication, because the challenges are now extreme. And we're going to hear a little later on how challenging they come when you're starting to talk about external validation in intended use populations and further modification as you move forward, which is a question from one of the external questioners. It's going to be fascinating to see how it evolves. So thank you very much. And could I just remind those that are in attendance, and I can see there's well over 100 at the present moment, please fire your questions and comments into us. They'll be collected and we will address them one way or another going forward. So let's move on to the next issue, which is the issue of trial design. And Carlo Senore will be the presenter and Lydia Guittet will be the discussant. Thanks very much, Carlo.
Sorry, this is okay. Does it work? Okay. Okay. Thank you very much, and thank you, Graeme. And this is I will briefly discuss about issues related to population and screening setting, and then the comparator test. And then I will address issues related to design and with a specific focus on prospective evaluation. Well, the target for the evaluation of new tests are average risk subject average for colorectal cancer in the target range for screening, but we should also consider the setting for assessing the test performance and for eventually adopting new tests. And in particular, when considering population-based setting, we should take into account that finding a balance between the need of higher sensitivity and the need to minimize the cost and harms represent a requirement in this setting. We had already heard about the comparator test in the paper in 2016. The FIT was indicated as a new standard test because in the context of randomized clinical trials, the test showed a higher sensitivity for colorectal cancer and a better capacity to detect advanced adenomas as compared to guaiac FOBT. But what is also interesting that you can improve the sensitivity of FIT, in particular for detecting advanced adenomas, with repeated testing. We had also, as an alternative comparator, sigmoidoscopy, which was suggested as a comparator for test detecting pre-invasive lesions. And given the long-lasting protective effect of adenoma excision, the test can be offered at longer intervals, and so it can be considered a comparator for one-off test. And in fact, we have much focus now on the introduction of new biomarkers. We have several new non-invasive blood or stool-based tests using biomarkers or biomarker panels. For this test, FIT can represent an appropriate comparator, given also that most of them will need to be repeated at regular interval. But there are also new imaging methods. We have data, comparative data for TC colonography and sigmoidoscopy or colonoscopy. And it was just recently announced that the colon capsule endoscopy will be tested within the UK screening program. These tests are more invasive and they can be offered longer interval. In this case, the comparator might be eventually sigmoidoscopy more than FIT. But in general, we should take into account the screening is a process of care. The performance of screening is the result of the test characteristics and the combination of positivity threshold and screening interval. And most comparative studies are focusing on test characteristic, diagnostic accuracy, and sensitivity on a one-off basis. But even on a one-off basis, it might be important to consider, when interpreting the result, the cutoff, the positivity cutoff, which has been used. And it would be advisable to have a new test having flexible cutoff. The performance should be measured simulating different cutoff level and focusing on the positivity range for the established population-based program, because the demand of endoscopy result, which is resources, which is driven by the positivity rate, represent one of the main determinants of sustainability of the program, and in fact, the possibility to modulate the cutoff to match the local endoscopy capacity might represent a requirement for a new test to be considered for adoption in the population-based program. And also to allow simulating comparison at different cutoff levels, fit positivity threshold should ideally be low in those studies where colonoscopy follow-up is offered only for subject testing positive either at fit or at the new test. But having a comparison taking into account the positivity cutoff might allow to get more accurate estimate of the test performance. This study comparing 9 quantitative fit methods showed that there was a large variation in sensitivity and specificity when using the threshold recommended by the manufacturer or when using a uniform positivity cutoff. But the sensitivity was very similar across the different tests when adjusting setting the threshold to obtain the same specificity or the same positivity rate, so that it can change the picture of the comparison. The choice of the different design can be related to the aim of the evaluation. We can broadly distinguish between studies aimed to measure diagnostic accuracy against the reference standard using a cross-sectional design, or we can have clinical utility studies aimed to assess the effectiveness and harms over the spectrum of the disease using a prospective design. In this case, the study sample should be representative of the population where the test is intended to be used. And in fact, we need a preliminary assessment of the test characteristic to support technical refinement of the test, to improve and to assess analytical validity, and to achieve a satisfactory reproducibility. But an early assessment of the diagnostic accuracy of the test in the population where it is intended to be used may be justified to address the spectrum bias. State distribution of and possibly the biological characteristics are different among screen-detected cancer as compared to clinical diagnosed colorectal cancer. And therefore, the predictive role of the biomarkers might be different. And ideally, cases and control should be recruited in the screening population. So we can consider to anticipate the evaluation of the new test in the context of ongoing programs, adopting the approach of pair design, offering both tests to the same people. In this case, although those who are testing positive to the established test, the comparator test, will be sent for colonoscopy, will be assessed with colonoscopy according to the program protocol. And ideally, also all those testing positive just to the new test should be referred for assessment, but considering the availability of resources and the potential negative impact on the organization or even on participation of programs, the one option might also be to consider sending for assessment just a subsample of those testing positive only to the new test. On the other hand, we can also consider having case control studies nested within the screening cohort to study the association between the positive result of the new test and the subsequent risk of neoplasia, even if this kind of study may be more informative for the risk of cancer as opposed to the risk of advanced adenomas, which would be detected just if you are repeating the test. In the prospective evaluation in the 2016 paper, there was the idea of having parallel randomized trial to assess participation, but also other outcomes related to the impact of the new strategies on a patient and on healthcare system. We should consider that the characteristic of the population enrolled in the ongoing screening program now may influence the result. We have now programs which have been ongoing for a long time, so we have no longer a screen naive population, and the detection, the prevalence of the neoplasia might be fairly low. And also there might be an association between individual screening history and they're likely to respond to different tests. So that all these aspects might be considered when evaluating the result. But the prospective evaluation might provide, again, meaningful and valuable information about the impact of the test. We know, based on the experience from other studies, comparative studies, assessing the impact of new tests for other cancer sites, for example, HPV testing against pap smears or tomosynthesis against digital mammography, that an evaluation over 2 consecutive screening rounds may provide informative result about the impact of the test. In fact, detection of early stage lesions is a goal, and therefore stage distribution of screen detected cancer at the first and the subsequent screening represent a meaningful intermediate outcome. But even if with existing tests, the overdiagnosis risk seems to be low for colorectal cancer screening, in a way that may increase the detection of indolent lesions. So if the test is able to detect those lesions which are more likely to progress, we can expect a reduction in the absolute risk of late-stage diagnosis or a more favorable stage distribution of screen-detected cancer at subsequent screening. And similarly, an increase in the detection of cancer at screening might be associated with a reduction of interval cancer. And here there is this paper from Gene Edison already now 25 years ago, comparing Guaiac-FOBT and FIT, showing that in fact the increase in the detection rate with FIT at screening was associated with a reduction in the interval cancer rate, so showing the superiority of FIT as compared to Guaiac-FOBT. A cross-sectional comparison of a test which need to be repeated to a once only colonoscopy, a single screening with colonoscopy, might underestimate the sensitivity of the test. Here are the results of a study conducted within a larger FIT-based population program, showing that the detection rate with 5 consecutive FIT examinations was similar as the detection rate with a single colonoscopy, both with respect with colorectal cancer and advanced adenomas. And the positive predictive value was only slightly reduced from the second round, but stable in subsequent round as a result of the continued detection of advanced adenomas, and while the detection rate of colorectal cancer was decreasing. So the information about interval cancer rate and a positive predictive value and program sensitivity can provide information to orient the choice about the optimal screening interval, which represents a driver of resources and the influence acceptability and cost of the program. So it had already been suggested that organized screening program can represent an ideal platform for conducting comparative assessment research using a prospective approach. And the learning program framework adopting a randomized design to assess the impact of changes in ongoing programs can facilitate the comparison of different tests and setting for introducing new technologies. And having, in the context of existing programs, large sample repositories eventually integrated with information about risk factors may accelerate the development and the testing of new screening methods. Thank you for your attention.
Thanks very much, Carlo, for that comprehensive overview of the increasing complexity that we face. So I'd like to hand over to Lydia now for you to discuss this issue. Thanks very much, Lydia.
Thank you. Thank you, Carlo, for this presentation dealing with many important elements of trial design for evaluating new screening tests at the time of ongoing screening programs worldwide. as Graeme told us at the beginning of this session, we are used to tests based on bleeding or visualization of lesions. And my first comment will be on the specific situation of evaluating tests such as blood tests, I mean mRNA blood tests, for example, which might detect different neoplasia depending biology, or even extracolonic lesions. So what about accuracy for other cancers in case using blood tests? Should other cancers be included as control in phase 1 or 2 trials? And what about the screening population in a prospective trial? What should subjects with a positive new test but no lesion at colonoscopy be told? Should they be explored for other cancers based, for example, on their personal risk factors for other cancers? And what about the risk of anxiety for those patients? Because we know what we can tell to patients who have a negative screening test, usually negative screening test, or a positive test, but a negative colonoscopy when we are using blood tests, fecal occult blood tests, sorry, for example. But what about blood tests? I think this could be an issue. And probably specific attention should be paid to the costs and complications of additional exams which could be performed to those subjects. And maybe incident extracolonic cancers could also be recorded to check the impact of those tests. My second comment will be, and Carlo told us about this point, on the impact of ongoing screening program on evaluating the new tests in prospective trials. First on performance, and second on the participation rate. Because considering performance, it should be noticed that introducing a new test within an ongoing screening programs should be considered at the first round as a prevalence screening round. And we know that prevalence of lesions are usually higher in prevalence screening rounds. But to the contrary, for the usual test, which is already used in the ongoing screening program, this is a subsequent screening round, so there could bias the comparison between tests. Also, in some trials, we could be interested in comparing several new tests with, within an ongoing screening program, but the similarity between some of the new tests and the test used in the ongoing program could also be an issue. And the first round could be like a prevalent screen or a subsequent screen, depending on the mechanism of the test. Then the problem of participation rate should be noticed, because some subjects can be could have reluctance, for changing tests, and their decision to participate could not be observed in real programs. So there should be also an issue. And maybe it could be interesting to stratify the analysis on the former participation with the usual test, or on focusing on new invitees just attending the age of screening. Thank you.
Thank you very much, Lydia. So the complexity of studies going forward in the current context of widespread screening is a very big challenge for us. We have to find efficient ways to achieve this going forward. Great. So let's move on to the next presentation, which I know has required some considerable discussion between the presenter and the discussant. So I'll hand over to Patrick Bossuyt for the presentation and to Anne Zauber for the discussant. Thanks very much.
Thank you very much, Greg. In the next minutes, I would like to present a few thoughts about the statistical approaches for evaluating novel markers. My key messages are that we have statistical approaches for comparing novel markers to existing ones, that these comparative evaluations differ from what you may know from single marker evaluations, and that in everything that we do, we should always consider the balance between true positives and false positives, and our statistical approach will vary with the phase of evaluation of these novel markers. Now, in this presentation, I will focus primarily on the third phase, where we will evaluate the performance of the novel marker in the intended use population. I will say a few words about these other phases later. So imagine that we have a novel marker. I will use the word marker to distinguish these from test in the statistical sense. So a novel marker based on finger prick blood. And our comparator, as Graeme introduced, is FIT, which is the current first-line test used in the population CRC screening program in the Netherlands. Then we should keep in mind that there are different ways on how the novel test could be positioned against the existing test. So one possibility could be that the novel marker, based on finger prick blood, is suggested as a replacement for the existing test. But that's not the only possible role in the pathway. It's also possible that we would like to position the new test as a triage test before FIT. For example, that only the ones that test positive on the new test would go on to have the existing test FIT. And it's also possible that we're going to position the new test, the novel marker, after the existing test. For example, to pick up FIT negatives and turn them into true positives. And the statistical approaches for triage tests and add-on tests and the type of studies are clearly different than studies for replacements. But in the remainder, I will focus on replacements. Before we consider replacing FIT, we should consider what is its performance? How does it perform? And I'm just focusing on advanced neoplasia, so the combination of cancer and advanced adenoma. At the 15 nanograms per liter cutoff, it's approximately around 40% for the combination and the 90% specificity. So that means if the diamond expresses the current performance in ROC space, so all combinations of sensitivity and specificity, we have a target region for a novel marker. Preferably, it should have better sensitivity and better specificity, so the green region. For example, this marker has a 60% sensitivity, better than FIT, and 95% specificity, better than FIT. It's also possible that we can look actually at different statistics with the same meaning. So rather than sensitivity and specificity, we can also look at this curve and look at the true positive rate, which is a synonym for sensitivity, and the false positive rate, which is MUN minus specificity. Now, in addition to the target region, it's possible that we can accept tests that are slightly worse in terms of true false positives, but have more true positives, or the other way around. So slightly fewer true positives, but less false positive. So our target region can be redefined into an acceptability region in ROC space, and that's where later on non-inferiority will come in. So for example, this tests slightly better sensitivity and slightly worse specificity. Now, why do I emphasize the combination of true positives and false positives? Well, better sensitivity can never be a goal in itself. For example, with quantitative fits, we can just move the cutoffs and achieve a higher sensitivity, more true positives, but that will come at the expense of more false positives. So there should always be a balance between true positives and false positives. Now, what type of studies can we conduct to evaluate the novel markers? Well, we can conduct the usual diagnostic accuracy study comparing a novel marker against colonoscopy. and classify the true positive, the false positives as true positives and false positives. And that will give us sensitivity and specificity of the new tests. Now we can make an implicit comparison by requiring in the statistical approach that sensitivity should be better than fit and specificity should be better than fit. And that means we will have to reject a combined null hypothesis, so it's a combination of two null hypotheses, sensitivity worse or equal than fit and specificity lower or equal to fit. So we'll now have a joint hypothesis that we'd like to demonstrate. A different kind of study compares a novel marker and the existing one fit in a single study, in a paired study. So all screening invitees have fit the novel marker and the reference standard. But there are some variations possible, which I will come to later. Now in that study, we not only have sensitivity and specificity of the novel marker, we also have the sensitivity and specificity of fit. And in a comparative study, we should include comparative measures of accuracy. For example, we can express them as the relative true positive rate and the relative false positive rate. How do the true positives of the new test compare to the true positives of the existing test, and the same with the false positive? And we should look at both in combination. How does that work out? Well, you may remember this study, Imperiale, from New England Journal of Medicine 2014, and this table, which did not include comparative measures. Well, we can calculate them for you. For example, if we again look at a combination of colorectal cancer and advanced precancerous lesions, then there were 60 for the multi-target DNA test and 321 precancerous lesions. So in combination, 60 plus 321 true positives. The numbers for fit are 48 and 180, so the relative true positive rate is 1.7. You will see that we only need the true positives for both tests to calculate the relative true positive rate. That means we could have done a study in which we evaluated only the positives against colonoscopy. Now, similar numbers for the false positive rate, which is at 2.6, the relative false positive rate. So we see a 70% increase with the novel tests, but also an increase, a more than twofold increase in false positives. Now, if we do a comparative paired study, we can define an alternative joint hypothesis. So higher relative true positive, more true positives, and fewer false positives. And again, define a combined null hypothesis. So if we reject this hypothesis, we can demonstrate superiority by looking at these comparative measures. The sample size will depend on the study design and the level of discordance of the two tests, and I don't have time to go into that. So if this is the point estimate from my paired study, and this is the line of equality, same number of true positives, then this shows that the new marker is superior. If the point estimate is on the other line as well as the confidence interval, then the new marker is inferior. And if the confidence interval overlaps with the line of equality, then we have an inconclusive study. Now, Graeme mentioned initially non-inferiority for false positives. What does that mean? Well, the new marker ideally should have fewer false positives. So in this case, point estimate and confidence interval are to the left of the line, fewer false positives, so it is superior. We can also define a margin to the right of the line of equality, which means that we will accept slightly more false positives with the new test if it is superior in terms of true positives. And if the point estimate and the confidence intervals fall to the light of that margin, we will conclude that the new marker may not be superior, but it's not inferior to the existing test, given that we also demonstrate that difference in true positives. Same if the point estimate is on the other side of the line of equality. And in this case, the new marker is clearly inferior because it's on the other side of the margin, and in this case, it's inconclusive. So we can combine hypotheses that claim superiority in true positives and non-inferiority for the false positives, or the other way around in this way. And again, it requires a combined null hypothesis. And there are existing statistical approaches for calculating p-values for these combined joint hypotheses and p-values to reject as null hypothesis. So we always have to consider the true positives and the false positives. We can increase sensitivity, but the question is, at what cost? How will the false positives increase if we increase the number of true positives? So we can aim for superiority for both, or superiority for one, true positives, more true positives, or fewer false positives, and non-inferiority for the other. Or if the test has other advantages, for example, a greater acceptability, we may aim for non-inferiority to fit both in terms of true positives and false positives. Because if the test has a higher acceptability and more people are willing to participate in screening, the yield in terms of population health will be higher than as it is with FIT right now. I discussed this approach for the third phase, in which we estimate test performance in the intended use population. In the first phases, I think we will not have estimates of sensitivity and specificity. What matters is the distribution of test results. And the program evaluation will look beyond in terms of evaluating the effectiveness of screening programs. So statistical approaches exist. They're different for comparative evaluations. Always consider true and false positive, and the statistical approach varies with the phase of the evaluation. Unfortunately, there's a great deal to be improved if I look at the existing studies, which is why we developed actually the reporting guidelines for diagnostic accuracy studies. And these reporting guidelines invite authors to be explicit about their statistical approach, including a sample size justification. But I'd like to remind everyone that these are not novel things in statistics, not novel things in study design, so the approaches are there, and we should consider our aims in order to evaluate novel markers and, in the end, improve the effectiveness of population screening for colorectal cancer. Thank you very much for your attention.
Thanks very much, Patrick. That was very clear. Anne, over to you for your comments. Thanks.
Thank you so much. Patrick, that was a beautiful talk, and you've made it seem very simple when it's very complex. I was impressed with the idea that you're taking. We want to consider the true positives and the false positives. I always read a sample size with what are we going to do for sensitivity and what are we going to do for specificity. But they're intertwined, and with considering the true positives and the false positives, you're really looking at the balance between getting it right and getting it wrong and all the consequences. If you're doing something for screening and send more people to colonoscopy than you need to, you can have more complications. But if you miss cancers, then the person could easily die of colon cancer. So you are always balancing those. And the way that you have presented it to us is to consider the true positives versus the false positives. I think is really a best place of understanding it. I'm going to go back to some of the other things that people have also talked about. And one of them is about the serrated polyp pathway. And we know that this is becoming more and more frequently found, more understanding of that. But I'm wondering, in terms of doing the sample size and the power of the studies, do we need to kind of consider the version of what was happening with the serrated pathway and what's happening with the adenomas? We know that more people, endoscopists, are finding the serrated polyps. We still don't know how vital they are. We think maybe 15 to 30% of cancers are there. So we might consider in our sample size different versions of the serrated polyp contribution as well as the adenomas. And in that session also, in terms of the serrated, I'm the coordinating chair for the CISNET modeling coordinating chair for the colorectal cancer CISNET models. And we are now working with Lynn Butterly with the New Hampshire Colonoscopy Registry to work on the serrated pathway. We have not had sufficient data to know what to do with how to the transitions. And we now have a new grant, an NCI grant, and we are just starting on that and so excited that we're going to be able to put the serrated pathway into our models. And I also wanted to, having the floor, to say about the models. I think that our modeling can really be helpful in getting the number of colonoscopies that you've been using and what progress you could get with one test over the other. We are open to working with you and doing some modeling. And as you said, you use the modeling to give some answers and maybe some opportunities to do so. But we always want to be checking out how our models work with the real world. So congratulations to a great presentation and for these thoughts.
Thanks very much, Anne, and thanks very much, Patrick. It's greatly appreciated. So we'll move on to the final presentation, and I'm grateful to everyone. We've pretty well kept to time, so and the large majority of the audience has remained with us, which is great. So the final presentation is from Rob Bresalier. The discussant will be Robert Steele, and the title is Feasibility of Population Studies and Regulatory Issues. Thanks very much, Bob.
Sure. Let me hopefully, okay. Right. So let me go up. Right. So Graeme tasked me with dealing with two issues. One is in designing studies to really answer the questions we want to answer and to get things out into the real world from bench to bedside. How do you ensure a sufficient sample size, especially in an intended use population? And then there's the issue of regulatory oversight. So we spoke about a number of these things today. Okay, obviously we want tests with high performance in terms of sensitivity and specificity. We need to take into account resources, whether we're dealing with opportunistic screening versus population-based screening, and what's going to cost. And this is how we as clinicians and clinician scientists really think about this. But there's the real issue of the long and very long and expensive process of getting things from bench to bedside. And I love this slide because it really depicts the multi-step approach and all the steps we need to take to get something from discovery to market. And so we obviously need to deal with the basic and translational aspects of this, the various clinical study stages going from phase 1 to phase 3 trials, but then how do you get things into mainstream value assessment? And finally, how do you actually get it out there to market with approval from various, not only organizations, but regulatory agencies, and who's going to pay for that? And
your slides are not showing up, actually.
Oh, okay. Let's go back. I'm sorry. Okay, just a sec. Okay. Give me 1 second. Let me see what I can do. Is it showing up now?
No.
Not
If
yet.
you want,
no.
I can share them for you.
Okay, maybe we'd better do that. I'm sorry.
Just say next whenever you want to move on.
Okay, I'll do that. So what can you show them then? Okay, why don't you go on to the, okay, let's just, this is what I was talking about. And so basically this is a long process, and we have to deal with not only how do we get things from the laboratory through early stage value assessment, but then to mainstream value assessment, and deal with both the aspects of coverage by acceptance by societies, as well as coverage and adaptation by payers. Next slide, please. And sorry, it's a little bit cut off here, but it's okay. And one of the issues is really, how do you get enough samples for intended use and the funding to do studies that are beyond phase 2 and 3 to real world studies that evaluate this in terms of its impact on the clinical impact. And I'll just refer you to that website from the Early Detection Research Network, which is an organization sponsored by the National Cancer Institute, where not only are we embarking on doing early validation and then late validation studies, but providing a forum for reference set and specimen sharing. And I do urge you, if you're looking for specimens to do this kind of research, to access that site. But certainly the availability of adequate numbers of intended use samples is something we're going to have to deal with as we go in these very large studies that look at new markers. Next slide, please. And so this is something we're quite familiar with, the phases going from preclinical discovery to clinical evaluation, and then ultimately dealing with disease burden. And as you go from phase 1 through phase 4 or 5 evaluation, clearly the number of samples required will increase dramatically, so that when we're dealing with defining population impact, you're dealing with literally thousands of samples. And as I'll show you later, the studies that are ongoing now to evaluate new colon cancer screening tests literally are dealing with 10,000 plus patient population sizes. And the issue is, can we really do this? It's expensive, it's time consuming. And if you really look at event rates for what we may be interested in, is it achievable? Next slide, please. One of the approaches that we've taken to this is through NCI's Early Detection Research Network. So that is to go through the various stages by looking at a variety of candidate markers through very organized, systematic approach with biomarker discovery laboratories, biomarker laboratories that are tasked with high quality specimens, and then validating this in an unbiased approach by separate groups. And as you go through each step, the stringency of what you need to demonstrate is progressively more. So we have a variety of go, no go steps until we actually get to the issue of real world evaluation. And how does this impact cancer care? How does it impact discovery beyond small numbers of samples to real world populations? Next, please. So let me show you a little bit of the data that gets to this point from a real world study that we've performed through the Early Detection Research Network. And this takes one of the study designs that Patrick spoke of. We want to look at collecting samples and evaluating in a screening paradigm, stool tests, blood tests. So we're collecting stool, we're collecting urine, we're collecting blood. We have various demographic data elements. We're doing FIT, and then eventually patients going on to colonoscopy so we can compare all these things. And so our aim originally was to collect about 10,000 studies, 10,000 subjects. And this is data through the first approximately 5,000 subjects. And you can see that if you just look at the screening population, our event rate for colorectal cancer in 4,881 screening subjects who had complete data sets is only 10 subjects, or a rate of 0.20%. This was a problem. This represented a very intense collection from both tertiary centers and practices. The good news was that most of these cancers were early stage cancers. If you look at screen relevant neoplasia, that is cancer plus advanced adenomas by classic definitions, this was somewhat better at about 10%. But the dilemma is, if one is to do these kinds of comparative trials and cancer is the endpoint in a screening paradigm, then our event rate is going to be quite small, and the number that are going to be needed in these trials is somewhat staggering. Next slide, please. So there are a variety of approaches to how do you get adequate event rates so that you can then go forward to regulatory agencies. And one is perhaps to enrich by age of screening population. If you're having a first-time screen in an older age group, there's a tendency for the event rate to be higher. And this has been very commonly used, although not often advertised, in some of the larger screening trials. And this is certainly what Exact did for Cologuard, and we see this in a number of types of trials. The other is to include primary practice networks versus strictly tertiary referral centers. And again, this has often been done. And one thing we've been trying to sell to regulatory agencies, and we'll see if they accept this, is could we take a combination of a screening trial where we're clearly looking at true event rates in a screening paradigm and supplement this with patients who have cross-sectional collections. These are patients who have had their cancers discovered through screening, still have in situ untreated screen-detected cancers in place, but can supplement the true screen-detected cancers. And an example is in our EDRN consortium, our prospective trial is called GLNE10, and we have a cross-sectional collection called GLNE7, and we've put this forward to the FDA. We don't know if they're going to allow it, but we'll have to see. So the issue is, in these large trials, do we have to really only include as relevant patients true screening patients, first-time screens, or perhaps those with screening within guideline-defined intervals that have not had cancers previously detected? Or could we supplement this with other groups, such as surveillance groups, where the event rate is going to be higher? So we don't know this, but these are real issues that we're coming up with. Next, please. So I try to have a little fun with this, and going back to that nursery rhyme, how do we determine which little piggy goes to market and which stays home? And maybe we need to follow the yellow brick road that includes inclusion in accepted guidelines. And in the United States, although the AGA and the ACG are very important, the U.S. Preventative Services Task Force really dictates to a large extent how regulatory agencies and payers look at this. So we have to have guideline acceptance by regulatory agencies such as the FDA, and then ultimately, who's going to pay for this? Will, for instance, the Center for Medicare and Medicaid pay for this, and what determines their criteria for how things will get paid for? Next, please. So in the United States, a regulatory pathway does go through, the FDA, and although there are so-called laboratory developed tests that have less stringency, more and more things have to go through the regulatory path. That includes a pre-market approval by the FDA. And the FDA, in fact, in its guidance, includes screening tests and biomarkers that define screening tests as a class 3 tests, which are the highest level of stringency. And then there has to be a reimbursement strategy, which includes acceptance by societies such as the AGA and the ACG and ACS, and the multi-society task force guidelines that are informed by these societies, but also who's going to pay for it? Does CMS, what will they accept? And how is this determined for a screening test? Next, please.
Hi, Bob. Just
yeah. Okay, it's going to be a, a long and winding road. Next, please. And as I said, tumor markers are considered by the FDA to be in line with medical devices, and they get classified by the highest level of stringency. Next, please. So these are class 3 tests, which are defined the most stringent category. And very pertinent to this is the fact that one needs to deal with intended use. And how is intended use defined? So this can be defined very broadly, but the FDA has often been very stringent in its definition of a test that is going to be out there in clinical practice be defined by the population in which it was tested. And how strict this is going to be is something that we're continually dealing with. Next, please. So we really need to define the target population clinical setting intended for use of a biomarker or screening test and ensure adequate generality in the population studied. And these are criteria that the FDA is very often rigid about. Next, please. You know, they're not quite as rigid as this, but we've mentioned in some of our previous talks the intended use populations. And that may get defined by subgroups of cancers, for instance, by molecular subclassification, or even genetic admixture. We know a lot of, most of our trials are done in very select populations, for instance, Caucasian population. Does this apply to other genetic admixtures? We don't know. Next, please. This just gives you an example of what CMS, which is Center for Medicare and Medicaid, has put forth as criteria for approval of a blood test for colorectal cancer screening. And they suggested a sensitivity of at least 74% with the specificity of at least 90%. And this has to be compared to a recognized standard, so which is they define as colonoscopy at this time. FDA has to approve this, and it has to be included as recommended in routine colorectal cancer screening test paradigm set forth by societies such as U.S. Multi-Society Task Force or Medicare and Medicaid. So this is another layer which you often don't think about, but is what is necessary to get something to market. Next, please. And I'm just going to be right brief. These are ongoing trials of a variety of tests, mostly blood tests that are either based on abnormal methylation or multi-omics tests. And I just wanted to use it to show that these trials are ongoing. And many of these, at least 4 of these, are designed with sample sizes of at least 10,000 subjects. And I know for sure, I know for a fact that getting back to event rate for cancer in these intended use populations, all of these trials are having trouble getting enough cancer-related endpoints in their trials, and are having to, I wouldn't say dilute the trials down, but at least look at alternative methods beyond pure screening of supplementing sample size. And to finish up, last slide, please. I want to finish with a couple quotes, one from Bert Vogelstein, who said, the number of cancer cases diagnosed annually by 2050 is likely to double as a result of population aging. So if we as a society hope to head off the coming storm, we better get more serious about cancer prevention soon. And then one from Dennis Burkett, if people are constantly falling off a cliff, you could place ambulances under the cliff or build a fence on top of the cliff, and we're placing too many ambulances under the cliff. And I'll finish there.
Thanks very much, Bob. The complexity of it is clear in the US. So we'll bob around a bit now. Bob, is it as complicated in the rest of the world?
Yeah, thank you, Graeme. I must say, I share your opinion that it's deeply frustrating not to be able to have a proper discussion here. And I would have loved to have discussed all of the presentations, but I'm particularly glad to be able to discuss Bob's presentation, which I think he has really illustrated the complexity of the problems we're facing very well, particularly the challenges of validation studies. But what I really want to talk about is the challenge of the regulatory process. When we communicated, Bob was clearly concerned that his talk might be too USA specific, and clearly that was the case to a certain extent. But I think we'll find that most countries have similar problems. So most countries will have a regulatory process like the FDA, which will examine the evidence on new diagnostic modalities, and approval from these regulatory bodies will be necessary before that modality can be marketed. However, in countries like the UK, which are largely served by socialized medicine, we often have to make very, I think, unpleasant decisions based on capacity and competing priorities. To take an example, in colorectal screening, the threshold that we use in quantitative fit in the UK is well above that used in most countries. And despite the fact that we have modeling evidence that the most effective threshold is in the region of 20 micrograms per gram of feces, we in the UK are implementing it between 80 and 120. So, and this is purely down to colonoscopy capacity within our National Health Service. And I think a lot of other countries face the same problems. And in terms of new tests, just because a new test is approved by our medical and healthcare regulatory agency does not necessarily mean that it can be implemented in national screening programs. Because for a national screening program to undergo a major modification, it requires a very high evidential bar, and the committee which I chair at the moment, the UK National Screening Committee, is very focused on looking at more benefit than harm at reasonable cost. And so we do, in our socialized medicine country, feel ourselves quite constrained. But on the other hand, we are very focused on using the resource that we have to the maximum advantage of the population. So I think the aim in the US and the rest of the world is the same. The way we go about it is going to be different from one country to another. And but at the end of the day, we are faced with a complex situation. We have to make difficult decisions, and we need to be absolutely clear that the evidence that we present to our regulatory bodies is watertight and will provide our population with the maximum benefit from any screening program. So I don't have any more to say. I think but I'll leave it to Graeme to sum up. But what a fantastic event! Thank you.
Thanks very much, Bob. Well, in fact, it's over to Carlo to sum up. So go ahead.
Thank you, Graeme, and of course, thank you to all the speakers and discussants for these very interesting presentations and point for discussion. And also thank you for all those who provided comment. As Graeme was mentioning, we received a lot of comment from different people, and just a small part of all these comments were dealt with in this discussion tonight, but we'll have the opportunity to continue this debate on by mail, and eventually also to finalize some additional discussion in the next meeting at the UGW. Well, in fact, there is one issue that came out from all these discussion, the presentation, is the fact that there is the need to pay attention to the context of the evaluation and use of the new test, and the fact that issues related to the context should lead to consider the flexibility of the test endpoint to allow adjustment of the cutoff or the test performance to ensure sustainability of programs. And there is some, let's say, challenge here in when we are considering the regulatory process, which usually consider the test as a one-off performance. So they are setting a very high bar for sensitivity and specificity, while in fact the test in the context of a screening program is used over on a prospective basis, and you need to consider the impact over time of this approach. So this is something that is in some way challenging, should be probably further analyzed during the reassessment of the phased evaluation in this group. We have heard a very interesting suggestion about the new possibility to define and characterize target lesions. And another issue which is really important is the need to get a better knowledge about and awareness about the algorithms which are more and more used to deal with biomarker panels, define the setting the performance of these new tests. They represent a promising approach, even if, as Tim Kortlever was suggesting, there might be some problems and some limitation in the way they are actually used. So these are, we have a lot of material and challenges to address during the next month of our discussion. And well, again, thank for the suggestion and the collaboration.
Thanks very much, Carlo. Thanks very much, everybody. And a special thanks to you, Alexandra. Why don't you flash your face up so that everybody can actually see you? And say
thank you, Alexandra.
Because putting something together like this has been challenging. And I think given the constraints and everything, the discipline of the speakers and etc. has been great. And the fact that we've been able to do this is wonderful. So sometime it'll be face-to-face, who knows when. Thanks, everybody. Goodbye.
Bye. Thank you very much. Good night, or have a nice day, Graeme.
Thank you.